Hai Lola, bentar. We are currently supporting this outreach session in Cross River, and today we decided to come and have an interaction with the healthcare workers and the caregivers.
This program now, it don't benefit you now. Yes. That she wants to give testimony about what this program has done.
I'm feeling so happy, sir, because as now that I have twins, it has not been easy.
We have been able to interact with them, ask them certain questions about the impact of the project on them, and some of them have commented to the fact that before the commencement of the school project in January, they have to travel far and wide to access immunization.
And so bringing the vaccines to their doorsteps make it very easy, and then also reduce the burden of partially immunized children.
Yes. Present situation right now, things are very tough. Sometimes parents, mothers don't go out because of transport. They complain of transport. So their doorpost movement have really helped us a lot. Like today, if I have to go to the health center now, I won't go because I don't have transport.
So the project has actually been a huge success in the fact that it has helped to reduce burden of partially immunized children and also burden of zero dose children. Thank you so much. Support Fund NSSF in partnership with IHS Towers. We are currently supporting this outreach session in Cross River, and today we decided to come and have an interaction with the healthcare workers and the caregivers.
This program now, it don't benefit you now. Yes. That she wants to give testimony about what this program has done.
I'm feeling so happy, sir, because as now that I have twins, it has not been easy.
We have been able to interact with them, ask them certain questions about the impact of the project on them, and some of them have commented to the fact that before the commencement of the school project in January, they have to travel far and wide to access immunization.
And so bringing the vaccines to their doorsteps make it very easy, and then also reduce the burden of partially immunized children and zero dose. Yes.
Present situation right now, things are very tough. Sometimes parents, mothers don't go out because of transport. They complain of transport. So their doorpost movement have really helped us a lot. Like today, if I have to go to the health center now, I won't go because I don't have transport.
So the project has actually been a huge success in the fact that it has helped to reduce burden of partially immunized children and also burden of those children. Thank you so much. Solidarity Support Fund (NSSF) in partnership with IHS Towers, we are currently supporting this outreach session in Cross River, and today we decided to come and have an interaction with the healthcare workers and the caregivers.
This program now, it don't benefit you now. Yes. That she wants to give testimony about what this program has done.
I'm feeling so happy, sir, because as now that I have twins, it has not been easy.
We have been able to interact with them, ask them certain questions about the impact of the project on them, and some of them have commented to the fact that before the commencement of the school project in January, they have to travel far and wide to assess immunization.
And so bringing the vaccines to their doorsteps make it very easy, and then also reduce the burden of partially immunized children and zero dose. Yes.
Present situation right now, things are very tough. Sometimes mothers don't go out because of transport. They complain of transport. So their doorpost movement have really helped us a lot. Like today, if I have to go to the health center now, I won't go because I don't have transport.
So the project has actually been a huge success in the fact that it has helped to reduce burden of partially immunized children and also burden of zero dose children. Thank you so much.
Good afternoon, everyone. Apologies for the delay in starting. We're starting now. Thank you for joining us for another session today. We hope that it's been a wonderful learning opportunity for us as the current participants on the NSSF Fireside Chats. Yes, so we'll just we'll start exactly 1:05. We'll just give a few minutes for other people to join us and then we'll start. Just want to welcome you once again to the Fireside Chats. Today we'll be discussing health economics. Welcome.
Thank you.
Good afternoon, Fejiro.
Good afternoon.
Good afternoon, sir. We can see you.
Okay.
Yes, thank you. We'll start in 1 minute. Thank you, sir.
Solidarity Support Fund, NSSF, in partnership with IHS Towers, we are currently supporting this outreach session in Cross River. And today we decided to come and have an interaction with the healthcare workers and the caregivers.
This program now, it don't benefit you now. Yes. That she wants to give testimony about what this program has done.
I'm feeling so happy, sir, because as now that I have twins, it has not been easy.
We have been able to interact with them, ask them certain questions about the impact of the project on them, and some of them have commented to the fact that before the commencement of the school project in January, they have to travel far and wide to assess immunization.
So bringing the vaccines to their doorsteps make it very easy, and then also reduce the burden of partially immunized children and zero-dose.
Yes. Present situation right now, things are very tough. Sometimes mothers don't go out because of transport. They complain of transport. So their doorpost movement have really helped us a lot. Like today, if I have to go to the health center now, I won't go because I don't have transport.
So the project has actually been a huge success in the fact that it has helped to reduce burden of partially immunized children and also burden of zero-dose children. Thank you so much.
Okay, thank you. Thank you. Good afternoon again, everyone. It's good to have us here. This is our second edition of NSSF Fireside Chat for 2024. And today we have a very interesting conversation. We'll be looking at health economics and how it affects our programs, especially with regards to immunization programs, maternal and child health programs. I know that it's not a very common subject. The economics of health is not a very common subject, but really what it simply means is that we have limited resources. Resources are not infinite. They are limited resources, and we have to allocate these resources to programs and activities in health that will give us good health indices as a country. So in a nutshell, that is what the economics of health in a very summarized version means. And we understand that the health system is struggling we have lots and lots of complex issues, from the fact that we have inadequate healthcare workers. We also have issues with our health governance. We have limited finances. We have data challenges. We have technology challenges. We have a variety of challenges, and we're looking at, and every program is calling for the attention and the finances for health. And today we'll be narrowing down to look at how we can bridge the current gaps, and what are the possible ways that we can assess the benefits of the costs being spent, how we can allocate, so have trade-offs, and then allocate our scarce resources to finance health services in Nigeria. Moderating to this session, we have Mr. Moses. Mr. Moses is a Chief Operations Officer at Yearbox Technologies Limited, a software development company. Prior to this, he served as a regional head of real estate company in southeastern Nigeria, bootstrapping office operations in Enugu, Anambra, and Imo states simultaneously. His other interests are in business operations, strategic business development, talent management, and project management. He writes and provides social commentary in different forums. And the past year, he has served as key panelist as TechDraw OU 2023, moderated several sessions in different tech mixes, and more recently in March 2024, moderated a 5-day in-person data analysis training session for educators and lecturers from the University of Agriculture, Makurdi. And today I hand over now to Mr. Moses to take us through this interactive session. Over to you, Mr. Moses.
Thank you very much. Please let me take confirmation.
I think we have to work on your volume. I can't hear you properly.
Okay, please confirm that that is better.
It is better, but maybe we can get
Please
more.
confirm that that is better now.
Not very clear.
Okay.
We can't hear you at all. I think we can hear you now. Can you speak?
Yes, please let's
Yes.
confirm that you can hear me correctly.
Yes,
fantastic.
thank you.
Yes, it's a warm afternoon from this part of Nigeria where I am, and I'm sure that it's a beautiful day for everyone else. I think this is the point where we all give thumbs up, where we all fantastic round of applause, even though it's from all parts of the world, to the Nigerian Solidarity Support for putting together this kind of discourse this afternoon. My name is Dexter, and I'm going to using to about 35,000 feet gauging the economics of health. Ladies and gentlemen, I want to thank you for your time for joining this session. Very quickly, we will be introducing the speakers and the panelists that are here on the conversation today. I'll very quickly run through the bio that I have with me. Okay, yes, thank you. Right about now, I'll be introducing the very distinguished Dr. Lukman Lawal. He's seated, and I think I like what looks like in his background. It tells you that we will be getting deep insights and deep discourse into a lot of the happenings in Edo State, and that can provide learning points for the subject of discourse. Dr. Samuel Ali is a healthcare management specialist. He's pioneer of the Nigerian health insurance industry and a trained gynecologist with interest in vitro fertilization. He has over 2 decades of experience in health management, clinical medicine, and administration. Dr. Ali has always shown leadership qualities and excellence in medical care. He has a distinction in anatomy whilst at the University of Jos, and is a pioneer staff of Unique Health. He has led his team to establish it as a premium brand, and he himself rose to the position of general manager within 3 years. He moved on from there to Hygeia Nigeria Limited, and is also touted to have improved general health, key governance structures at Lilly Hospital. He left there to become the MDC of Nigerian Police Health Insurance Limited, and is now currently the Honorable Commissioner for Health in Edo State. He's our first panelist, a very distinguished gentleman, in whatever way makes it comfortable for you. Ladies and gentlemen, with emojis, with interesting shouts from the inside, can you please welcome Dr. Samuel Ali?
Okay, good afternoon here, and hello to everyone, wherever you may be watching us from.
Yes, we're excited. We can hear.
I'm glad to be here.
Yes. We're excited to be having this conversation with you. My apologies for the mix-up here. A while earlier, I was looking at Dr. Lukman, and I thought it was Dr. Ali because I hadn't seen his video, but now that I can see him, it makes for better sense. All right, we will jump right into it and see that we can make very good use of the time that is available to us. Dr. Ali, a lot has been happening in Edo State. In fact, in the last couple of years, there's been so much in terms of progress. Let's hear from you. Let's get a context. Let's get insight as to what Edo State is journey for health and the health industry is like in Edo State. Sir.
Okay, once again, thank you very much. I think the first thing in improving health, especially in an environment like ours, is to get the political buy-in or the political will. And that is what has been the most significant and important success factor in the Edo State health space. The Governor Baseki, right from inception, made health his key priority. You know, the health sector to be one area in which he feels that they need a lot of improvement. And so, as way back as 2018, he set up a team to develop the Edo State Health Care Improvement Program, which essentially is like a roadmap towards what should happen to the Edo State healthcare space. So, with that roadmap begins a series of interventions in the healthcare that we are witnessing today. So it's not just something that just came from the blues. It was a well thought out program that we are executing in our state. And the first thing there was, first you need to look at the resources of the state. What's the status? Edo State happened to be one state in which it has one of the highest out-of-pocket payment for health in Nigeria, and in fact in the entire world. It's 90%. WHO recommend 20 to 25%. So you can see the national average is 75. So that's a huge problem. That means Edo State citizens were basically on their own when it comes to health issues as at 2019, 2020 figures. And that motivated the governor to set up the Edo Health Insurance Scheme, which provide people with access. So, after that, he looked at the we need to now look at the infrastructure. And 2020 opened the governor's eye to the fact that there's just a dearth of that in the state, the 2020 COVID. And also, not only in terms of infrastructure, it's also in terms of even the manpower. In terms of both quality and the quantity. And so he realized he had a lot in his hand. And therefore, that gives birth to reinforcing the management style of the state primary healthcare. He had to change the top management that could align with his own vision and that could actualize or implement his own vision in that regard. And therefore, the concept of being able to implement the concept of one primary healthcare under one roof is needed that the primary health cares that are scattered all over the state, over 400 of them, there was no one actually overseeing. There was no accountability, just literally all over. And then he now had a design. Let's have a design. How should our primary health care look like? What are the things that should be there? Who are supposed to manage? All of these come in. And he said, look, so let's start. And that year, 2019, 2020, he renovated and equipped 20 primary healthcare and said, yes, these are models. So we have 2 designs for our primary healthcare centers based on the population. So if the area has a large population, then the design is different. And when the area the population is much smaller, the design is also different. So those are the 2 designs that we came up with. And then we implemented it. So between then and now, we've done over 60 of that, standard ones. And he went further to notice that despite these improvements, the people were also not very, the trust has gone. So people are not accessing it. So we have to begin to use technology to bring in Association of Nigerian Physicians in the America, AMPA, who came in, and then after they left, they said, look, I don't just want you people to come and then you go, and then that's all. No. How can you maintain your presence even if you are not here? And then the idea of the telemedicine came in. So, so that's one aspect, making sure that there's health insurance, and then the place to receive the care, that's the infrastructure, and then the human resource, also looking at it. Then, of course, the primary health care itself, primary health care centers itself are not enough to provide for all the healthcare needs of the state. And that simultaneously informed the fact that we need to look at 2 other areas. The manpower engine or the manpower supply area, which are the schools. The School of Nursing the teaching hospital was a problem for the state. And then the School of Health Technology. So the governor began to look at these areas. And then also the tertiary institution where the doctors can be trained. So we now have the Edo Specialist Hospital, which was renovated, reconstructed, and now equipped. Not only being equipped, but the governor made sure that it was managed by management consultant, that is a third party, which one of the government, to ensure that that structure, which costs billions of naira and all, are maintained, well maintained, and that the people who work there are also able to imbibe proper culture of communication, treatment, and all of that are desired in this century. So those were the things he put on ground. But again, like I said, you looked at the supply side. The School of Nursing was closed down for many years. The governor has to revamp it and ensure that it meets to world-class standard. You can go there and see it. So that it now serve as a center for learning in a conducive and standard environment. The first set of such students will be graduating after 3 years this October. So that's why, and then the School of Health Technology, we also had to revamp it. Now we have, that one will be completed in July this year. So then we looked at the Auchi General Hospital, and then it was converted to the Edo State University Teaching Hospital. Because we already have Edo State University, but we didn't have a hospital, which so that was also done, upgrading, innovating, and equipping the Stella Obasanjo Hospital. So these are all the things that we've done to ensure that the healthcare space in Edo meets international standards. And recently, earlier this year, in partnership with ERA, we launched the Edo State Emergency Service, which is the first in the state. The state never had emergency medical service. And so that was the first, so that when people have emergency, they could call number 112-739, and promptly an ambulance could pull up and attend to them. We've also launched earlier this month, in conjunction with the United States Consul General in Nigeria, Mr. William Stevens, we launched the Integrated Public Health Emergency Operations Center, which is different from our emergency medical service. Now, the emergency medical service has its own control center, which is the normal emergency for non-contagious disease. But the Public Health Emergency Center is for outbreaks, for management of outbreaks, like Lassa fever, COVID, those epidemics that cannot be handled by conventional means. Now have a center in place, the first in Nigeria, actually. So all of these are what we have done in order to reposition the state, not to leave out the fact that despite doing all of this, we also have to look at the fact that the state healthcare in total need to have a regulation in place. That is the medical facilities regulation. And since last year, we kicked it off in full force, ensuring that the people of Edo State, wherever they are, they can receive care in an atmosphere that is clean and that is from a healthcare professional that is recognized. So all of these are what we are doing. And in the past since we started this regulation in August 2023 till now, we have shut down over 150 hospitals, not just hospitals, let's just say facilities, who have not met up to standard due to either practicing beyond their coverage, using unqualified personnel, not having approval, and maybe possession of expired drugs or things like that. So all of these are what we are doing to ensure that there's standard even in the entire state, to ensure that there is we maintain standard even in the private facility. So before anyone could operate a medical facility, I don't want to use the word hospital because it's beyond that. We're looking at pharmacies, hospitals, clinics, orthopedic centers, physiotherapy centers, eye clinics, dental services, anything that has to do with medical. We need to regulate. We need to seek their approval. They need to seek their approval. Is this building even conducive for such? So we will need to get that. Is this building registered with the government? The people that are working here, are they certified? Are they professionals? What do you have what are the equipment you have or the infrastructure in place to be able to render the kind of service you have claimed you are rendering? So these are also what we are doing in Edo State to ensure that Edo State citizens receive the best care in a safe place that has standard that is comparable anywhere in the world. We are not yet there, but we are not yet where we want to be. But no doubt we are making effort vigorously to be where we are. Now, in relation to your health economics, you can see that one way in financing health is through insurance, and we are vigorous in that. Recently, we have a law backing our health insurance. And recently, the governor gave a bite to it by ensuring that every employer that has 5 or more employees need to be registered with their health insurance. The goal is to have at least more than 50% of the population enrolled in health insurance, which can translate to a lot of benefits, not only to improving the care given at the center, but even in the infrastructure that is in place. So I've just, in this short time, I hope I've not spent so much time, giving you a brief of what we are doing currently in Edo State. And I hope I've not bored you with too much details.
No,
Thank
absolutely. You. I think there's been a fantastic encyclopedia of work or talk, meeting, action. And I think that Edo State is better for it. It speaks of courage, speaks of the willpower to do the right thing. You've spoken a lot about the infrastructure, manpower, distribution of healthcare across the state. Very recently, if I'm not correct, I think, if I'm not wrong, sorry, I think you rolled out the HPV vaccine in Edo State. Maybe in a minute or two, maybe you can walk us through that too, because we find that that's in its own right.
Okay. Yes. Thank you very much.
Sort of bragging, right? So can you just give us insights on the rollout of the HPV vaccine?
Yes, we did. We just key in. It's not a repeat program. We just key into the national program so that on the 27th of May, we launched the Edo State human papillomavirus vaccine. Now, this vaccine is very important part of safeguarding our people, or say preventative measures, actually. Cervical cancer is one of the leading causes of morbidity and mortality. That is sickness and death. We don't pray for any woman to have cervical cancer, even if they are detected early. We go through a lot of treatment. No one wants that. The financial burden, the economic loss that is associated with it is high. So, but the good thing with cervical cancer is that it is preventable. It is one of the preventable cancers in the world. There's a virus responsible for it. And that virus is the human papilloma virus, which is sexually transmitted. So the vaccine is given to girls that are aged 9 to 14 years, because that is the age in which we believe, or it is found, that most ladies are not sexually active. Since this virus is transmitted sexually, you give it so that people build their immunity even before they begin to have Children's Day. The governor was there, the first lady was there, the children were there, so they were able to listen and grasp the need for it. It's very important to create such awareness, because people have some advice to vaccine generally. They feel it's a way to control Africa's population, or some weird superstition about it. So it was a great day, because people now know why they should have this vaccine and this immunization, and that is what we did, and it was a success story.
Okay, thank you. Because of the exigency of time, I just want to run on this last question. Please confirm that you can see what I'm sharing on the screen. So from excerpts of the quarterly reports of the Nigerian Primary Healthcare Development Agency, we've been able to do some analysis on Edo State, and we can see that sampled women whose delivery were attended by skilled birth attendants. Edo State has not just met but surpassed the global rate or global standards that were set. And then for a couple of others, a couple of other priorities, like the WHO global target for proportion of children appropriately immunized for AIDS, that we're not exactly meeting the global standard in those states. Would you want to speak to this in a minute or two, sir?
Okay, the audio was poor, but let me just.
Okay, can you hear me again, sir?
Okay, you are saying there's for the proportion of children immunized for their age, Edo State is below the standard. But for what's the other first question? What's the other first question?
Yes, the other one was we could easily celebrate this other one that Edo State has surpassed the global standard for women whose delivery were attended to by a skilled birth attendant or done at a health facility.
Okay, so for the immunization, we are working on that. Logistic has been a problem, but we've surpassed that. Another thing has been the cold chain system. But we have developed strategies now. We are installing solar system in all our PHCs in order to be able to surmount some of these challenges. Because if you don't have that, then you'll not be able to give the vaccine as it is. And we're also creating awareness, ensuring that in the communities where primary health cares are located or centers are located, we go around to sensitize, we engage the community. We engage frequently community sensitization. And part of the integrated public health center that we launch, one of the things is to use it as a coordination hub for vaccination. And immunization is one of them, for immunization, sorry. And this immunization is one of them. It helps us to track in real time where people are lacking. So in summary, we are carrying out advocacy, engaging more in communities in order to close these gaps, because we have found out that it is more of creating awareness, because in the process of creating awareness, you dissipate fears or the superstitions or beliefs that people have against immunization. That way, we'll be able to meet global standards.
Okay, sir.
Hello?
We are indeed very thankful for your time. Thankful for the insights that you have provided into the journey in Edo State on very many fronts. We would have loved to have conversations around primary, secondary, and tertiary years, insight into your plans, but we hope we can have some of those insights when we would have time for question and answers, and we're very hopeful that you would also stick around for a few minutes more. We crave indulgence to please stay with us for a few minutes more. We'll take on the next panelist and the conversation going, and come back to you with a few questions later, sir. We thank you so much for your time, ladies and gentlemen, on this in this event. I'd like for you to please, by way of emoji, express gratitude and appreciation to Samuel Ali for providing valuable insights and for speaking to a lot of the work that is being done in Edo State. If you don't mind, please join me by way of emojis and say thank you to Dr. Samuel Ali. In very quick fashion, we'll be running off. We will be speaking through another gentleman who is a key opinion leader at the intersection of clinical medicine, global health, and business development and technological innovation. He holds a Master's of Public Health from the University of Minnesota and further qualifications from the Harvard School of Public Health, as well as the London School of Hygiene and Tropical Medicine. He's at the forefront of global expansion of the prestigious Mayo Clinic platform. I'm sure many of us are aware of that. He is instrumental in driving the development of dissemination development and dissemination of state-of-the-art digital health solutions, quite a number of them to mention. He has influences that span Kenya, Nigeria, Ghana, Tanzania, Saudi Arabia, Qatar.
Okay, so let me just take over from Mr. Dexter. I think we
Economic Forum's digital healthcare working group is very exhaustive. But if you may at this time also. Okay. Please confirm you can still hear me and that I'm not lost.
Mr. Dexter, we're having problems with your audio, but let me just take over the moderation at this point. Thank you so much. I think we've listened to the bio of Dr. Lukman. Dr. Lukman is a global expert in health economics. He has some background degrees in, he has an MBA and an MPH from the prestigious Harvard and Johns Hopkins University. He's a known person and somebody that is so passionate about funding healthcare, especially in LMICs. Dr. Lukman, you're welcome to the series of this fireside chat. It's a good pleasure to have you here.
Thank you so much, and I feel honored and thrilled to be invited to this conversation. And I'd like to thank the organizers, the NSSF. I'd like to thank my co-panelists, Ms. Kemi Olaoye and the Honorable Commissioner for Health, Dr. Ali. And, before I start, I love to try to contextualize health economics. I really liked what Ms. Fejiro Nwoko talked about when she started this conversation this morning, or this afternoon in Nigeria, actually. So he talked about resource allocation and the continuous fight and friction between infinite wants as well as finite resources. But for people like us that like to not overstress our brains, we like to use frameworks a lot. So these finite resources can be categorized using the World Health Organization framework. Anything we talk about health systems. Health systems is not a single thing. It's a combination of different units that work together to give you the kind of outcome that you want to get. And these health systems have been kind of divided into 6 building blocks that need to work in unison to be able to get us the kind of health outcomes we want for our population. And what are these 6 building blocks? Because I would love every attendee of this conversation. I'm sure many of us have heard this over and over and over again. And it's just to simplify the way we talk about this in terms of health economics. The 6 building blocks we are talking about are leadership and governance, service delivery, the medical devices, materials, as well as medications, health information and research, health financing, and health workforce. These are the 6 building blocks. And when you talk about leadership and governance, what are we really talking about? We are really talking about what are the plans, what are the programs, what are the processes, what are the procedures that the country has in place to advance health outcomes for their population. And plans could be in ear and hearing care, could be in maternal health, could be in surgery. So which kind of plans do we have in place for our country? What are the visions? What are the missions that we have in place to advance health outcomes? That has to do with the leadership and governance. When we start to talk about service delivery, the Honorable Commissioner talked a lot about the primary healthcare centers, the secondary healthcare centers. So the service delivery has to do with the primary healthcare centers, the secondary healthcare centers, the tertiary healthcare centers, and in some climes, we have what we call the quaternary healthcare centers. How are these functional? How are these really being leveraged to improve health outcomes for our population? So that's the service delivery component. Then when we talk about the medical devices, the materials, as well as medications, these are the pharmaceutical products, these are the medical devices, and how well do we have the supply, and how does the supply chain work efficiently to really be able to provide what we need when we need it to the people that need them. Then when we come to the health financing, how and what are the ways that we use in providing finance for health. The Honorable Minister talked about the health insurance system. What are the other innovative ways that we are using to provide health financing to really help improve health outcomes for our people? And when we talk about health information and research, now we talk about data is the new oil. How well do we have our data captured? What is our electronic medical record like? How best are we gaining insights to help improve the administrative efficiency of our work? And how are we translating that to really helping improve health outcomes for our patients, for our people? Then lastly and not the least, health workforce. And this is one of the things that I think technology as well as innovation has started to really help improve health outcomes with. Health workforce is a very key component. And I think based on the Honorable Minister's conversation as well, we kind of understand the different cadres of the health workforce, be it the physicians or the medical doctors, as we call it. We have the pharmacists, we have the nurses, we have the lab scientists, and a myriad of others. How do we really have a system to really bring them from the pipeline? How do we train them? Do we have enough training facilities? Do we have enough balancing between the supply and the demand? And if we don't have that, how are we leveraging technology? And for me, I think that's one of the most interesting parts of this. How are we leveraging AI, machine learning, generative AI, LLM, and many of the new, very interesting things that are happening all around the world? The example I like to give is, for example, I know there's a certain amount of radiologists that we need per capita in our country. I'm sure we are far from what we have. The same thing with cardiologists, the same thing with OBGYN, the same thing with gastroenterologists. How are we able to leverage AI and machine learning, which is already in existence, to start to read CT scans, MRIs, chest X-rays, to really leverage that technology and bridge that inadequacy of the workforce gap that we have across the different disciplines in Nigeria. So with that said, I think my idea is, how do we contextualize that friction between the wants and the resources we have? And the resources in this context, I've tried to use the WHO framework, leveraging leadership and governance, service delivery, the medications and materials that you need, the health workforce, health information and research, as well as health financing, to really understand and contextualize the different demands for the resources, as well as the inadequacy we currently have in our country and across most of the African countries, and how we can leverage new technologies as well as innovative ways to bridge that gap for health workforce, for health financing. How do we really, for health workforce, I talk about AI, machine learning. For health financing, how do we really bring about innovative financing mechanisms? How do we bring about the public-private partnership mechanism to really start to help bridge that inadequacy in financing part? How do we leverage CSRs from different organizations? How do we leverage international development organizations funding to also come to Nigeria and come to other parts of our countries, and not only being domiciled in some specific parts of the continent? How do we leverage existing funds within the country to really help improve health outcomes? How do we start to see healthcare as a business and beyond just social services? How do we really start to advocate for government at different levels, be it the state level or the federal level, to start to think of privatizing some parts of our health institution in a way that makes it more efficient, that unlocks the debt capital that we have in those health institutions? I think for me, I think that's more of what my introductory statement will look like, remembering the 6 building blocks of the health systems. And in another vein, to also make it simpler, if the 6 building blocks seems kind of very complex, you can always remember it in this way that for us, we like to keep things simple. The 4 M's, which is the manpower, the methods, the money that is required, as well as the materials. How do we really work around all those required resources to balance the need for the wants that we have? And I think that's the fundamentals of health economics and the challenging friction between the needs and wants, as well as the resources we want. I think I've spoken a lot. I'll leave it to the moderator to ask more questions.
Thank you so much, Dr. Lukman, for giving us that great insight into the intersection of innovation in healthcare and our own specific structure of the Nigerian healthcare system. And of course, you are giving us a great overview of that. I just want to ask that, looking at from your own experience, as a global health player, what specific challenges do you think we will face as a country, considering the fact that some of these innovations in healthcare may be difficult to get to some areas in the country? Nigeria is still grappling with a lot of infrastructural challenges, in terms of communication. There are communities where the communication is not good. There are communities where you don't even have the structure to carry out certain things. One of those things is EMR, for instance. If you get to a rural community in Nigeria and they don't even have the opportunity for digital health tools to use. So what are some of these challenges that you think will face in Nigeria getting to that level, and how do you think we can actually bridge this gap?
Oh, thank you so much, Dr. Adiribigbe. And for context, Dr. Adiribigbe is a very good friend, and he and I have always talked about these challenges and how we think some of these things are low-hanging fruits, how we could go execute some of these and really get Nigeria health system to where it needs to be. And I think for me, like I said earlier, I like to try and keep things simple. I've thought about that, and I kind of brought it to about the 4 C's of how do we really understand the challenges that our country currently faces in terms of leveraging more of the innovative ways of advancing health outcomes and really balancing the needs and wants with resources that we have in terms of resource allocation. And the 4 C's, I'll try to reel them out. And one is connectivity, which you've clearly articulated. The other one is compliance. The third is capital. And the last is culture. And I'll try to go into this as much as I can before the end of this conversation. When you talk about connectivity in the sense that when we talk about leveraging AI, machine learning, and many of the advancements and trends that will help integrate digital healthcare into our health systems, there's a need for connectivity. And, internet and digital infrastructure are key. How do you start to think about the end user hardwares? How many of our hospitals even have the number of laptops that is required for people to be able to work, end user hardwares? The connectivity, that's internet. How stable is our internet? How stable is our internet? I think, for example, even this conversation, we've had some glitches, and this is like one of the best places where you can have kind of webinars like this. There's a ton of places where you don't even want a 30-second downtime when a patient is at the ICU and you are dependent on this connectivity to get information from all around the world to manage your patient in the ICU. If connectivity is not good, the life of the patient is in jeopardy. That is one. We need connectivity, and it's a major challenge. The lack of reliable internet and digital infrastructure connectivity is one of our major problems. How do I see a potential solution to this? There are no two ways about this. There's no brainer. We don't need a witch doctor to explain to us. For this to work, we need to invest. We need to invest. We need to invest in digital infrastructure. That is where the world is going. We need to invest a whole ton in digital infrastructure, such as mobile networks, internet connectivity that can supply and support telemedicine, leveraging AI, machine learning, and other applications that many countries that look like us, not even the advanced countries. You go to places like Kenya, you go to places with similar per capita income, they have really been able to break this barrier to a good extent, and we can learn from them as well. So connectivity is a major problem. Secondly, the second C I have on my piece is compliance. Compliance in this sense kind of broadly describes our regulatory barriers, because many VC firms, many private equity firms, many organizations and institutions are looking for cheaper places to innovate. And why they're looking for that is they are really looking for how do we accelerate our innovation in other parts of the world? Do we need to take our innovation to China or India or Australia? Some have taken it to Kenya. How do we really make our regulatory environment very welcoming? What are the policies that are required? Because currently we may have a hodgepodge of different regulations that kind of serves as barriers for investors to really come in and really invest in healthcare and health system digitalization. So how do we start to overhaul our overdated regulations that does not accommodate new technologies? We need to really review that. And I think we need our policy advocates to really be able to engage the regulators to make them understand the upside mid to long term, the potential of really making our country a haven for innovation when it comes to digital healthcare, when it comes to healthcare technology. So it's important. The compliance issue needs to be kind of taken care of. The regulatory barriers needs to be taken out so that people see us as the mecca of innovation when it comes to healthcare. That is key. The capital piece, which is my third C, is we have funding limitations, and we can all agree with that. The difficulty in securing funding and capital for innovative projects really mars our country's ability to kind of get to where it needs to get to in terms of health outcomes for our people. And that challenge of really not having maybe a dedicated fund or a dedicated bank to fund healthcare innovation is a problem. And I'll give an example. For innovations to work, I used to be at MIT, and there's a mile square in MIT that is tagged the most innovative mile square on the planet. And why is that so? Where within that mile square, it's called Kenda Square, we have the MIT, you have the regulatory authorities, they have the offices, you have the financing institutions there. And what does literally happen is from the classroom, once you leave the classroom, any new knowledge and solutions you got from the classroom, you can literally walk into any bank, any financing institutions there. We have entrepreneurs there as well, and you can really talk about what you have, you talk about your ideas, and then you can really get other funding for that. You can walk next block to the regulatory agencies that will be able to approve what ideas you have. So like really bringing that ecosystem together in a way that you have the financing agencies, you have the government present, you have the entrepreneurs, you have the corporate organizations, and you have the academic institution. So I think that is more of a model that we can start to look at when it comes to healthcare innovation. And we need to also be able to have funds that are dedicated to healthcare innovation, either at the state level. I'm an advocate of subnationals. And I'd like to speak to some of the good work that the Ministry of Health is doing in those states. How do you start to think about innovating in healthcare? How do you start to push the state governments to start to set some funds aside, either through corporate support, either through international development, and dedicate such funds into healthcare innovation? I think that's key. So that's my third piece, which is capital. Then the last, my third C rather, the last C is about culture, and this culture is around educational barriers. The lack of awareness and education among our healthcare providers and patients on using new technology is also key. How do we start to raise that awareness? How do we start to provide that capacity building for all our doctors? It may amaze you that a ton of our doctors in the hospitals where they work currently today may not be using the EMR, the electronic medical record system. And at this age, if you're not really leveraging something as simple and basic as the EMR to provide services to your patients, then you're like some 1,000 miles behind. People have really moved forward. So how do we really start to create that awareness, that capacity building, that investment to solve the connectivity problem, to solve the compliance problem, the capital problem, now the cultural problem? So those are my 4 C's when it comes to the challenges I've seen and some of my ideas of how we could resolve those.
Thank you so much for that expose, Dr. Lukman. I know that if we give you the opportunity, you continue to speak about healthcare in Africa, something that, of course, like you alluded to, has been in the conversation between yourself and myself for some time. And I'm sure that you want to continue to find solutions and speak about that. But lastly, let me just say this, that considering how the wealth of experience you bring into health innovation, especially financing some of the startup innovations in Africa with regards to some of these challenges you have mentioned. How do you think that, because Nigeria's budget, sometimes we can't even budget up to 15% for health as recommended, by the Bamako Initiative so many years ago. Putting so much funds into the healthcare space has really been a challenge. And that's because not necessarily because there's absence of political will, but really because there are so many competing needs that government needs to do. Nigeria has so many challenges. We have the security challenges. Security is one of the things that has, been the highest consumer of our Nigeria's budget in the last few years. We have the educational aspect with its own challenges. So how do you, think that we can leverage using all the resources available to us to pull those resources together Because sometimes you find out that this partner is doing this thing, this person is doing this other thing in this area. How do we bring everybody under one umbrella to ensure that there's so much focus, in trying to solve some of this problem? Because sometimes we just have parallel programs going everywhere and there, and then there's really no coordination. So how do you think that, in your own experience, we can bring together a more coordinated approach to solving some of these challenges that you have rightly highlighted?
Oh, thank you so much, Dr. Diribiwe. I'll try as much as possible to be brief. And yeah, like you said, there's an issue with parallel programs going on. There's lack of coordination. And the challenge that brings is there's always over deeping, someone duplicating the efforts of others. And at the end of the day, you're wasting resources. And those are challenges when there's no central coordinating system, even at the subnational. It doesn't have to be a national. I'm more of an advocate of subnationals. Let's try as much as possible to, yes, for national level, the policies and stuff needs to be taken care of, but more of what is closer to the people is the subnational, the state government. How do we ensure, even at the state government level, even at the subnational level, there's a coordinated fashion of doing things when it comes to healthcare, so as to prevent duplication of international development organizations, dollars flowing into the state, and many other organizations working in parallel. There needs to be a central coordinating unit within the Ministry of Health and Human Resources, Ministry of Health and Human Welfare, to ensure that there's no duplication of effort. But with that said, when it comes to really seeing how we could leverage financial technologies to transform healthcare systems, there are some ways. Like I said, I like to not overburden my brain when I think. So the way I thought about this is like, see how can kind of divide into about 4 Ps, and that has to do with how do we really start to look at our payments? How do we look at partnerships? How do we look at public-private initiatives? And how do we really look at our people in general? So when we talk about payments, there are really nice advancements that has happened even on the continent of Africa when it comes to financial technologies. There was a piece I currently published about a month ago in the World Economic Forum, speaking about how do even the West, where I live, how do we start to look at what is happening in Africa, especially in Kenya, when it comes to mobile money transfer. And as of today, if I may tell this audience, like 70% of mobile money transfers occur on the African continent. That's impressive. And what that talks to is like, yes, there's a potential to be able to leapfrog health tech the same way fintech has been leapfrogged. But I hope we as Nigerians, or Nigeria, does not get left behind if we don't really key into these advancements that are happening. And what do I mean by that? There's this M-Pesa, which is more of like a mobile money system that has been perfected in Kenya, and one of the leading mobile money works in East Africa. And I believe utilizing fintech solutions like that can start to help improve health care financing. And what do I mean by that? A lot of our telcos, telecommunication companies, can be brought on board to really see how we could leverage some of their existing infrastructure, some of their payment system, to help improve how some of this funding for healthcare can work. For example, there's this company called Zuri Health. It's out of Kenya as well. They have offices in Nigeria as well. Some of their patients make payments through their airtime, right? So, and there's a matching payment that also comes from telcos. So yes, a lot of these people are able to load recharge cards, but like they're not able to pay their doctors, or they're not able to pay their pharmacists when they go buy medications. But there's a way their phones and their lines are integrated into a way they can use what they purchase in terms of airtime to pay for some of those services. So mobile payment platforms that allow patients to pay for healthcare services in manageable installments is a way we can really start to think about innovating in healthcare financing and payments. But that's not going to be the magic bullet. That is just a piece of the pie. And that's not even the most advisable piece, because that's not health insurance. Health insurance is what we always ask for, and that's what's always been advocated for. How do we leverage ensuring that a large chunk of our population are covered under universal healthcare coverage? And part of the World Health Assembly agenda and what the Ministry of Health is working towards is how do we ensure every single person who resides in our country has some form of coverage, either through the public system or through the employer system or through private coverage. And that's more of how we can really start to think about that. And how do we bring what we call the InsurTech? These are technologically driven health insurance companies that are able to leverage data from their patients to provide some level of financing to provide improve health outcomes for them. Then the next P I have on my agenda is partnerships. It's important to start to think about developing business models that ensure mid to long-term viability and diversified revenue streams for healthcare providers. And this also speaks to what are we doing with our public health institution at the federal level, at the state level? Is it high time we have these tough conversations around privatizing some part of that and government really working towards ensuring they unlock that asset in a way that more efficient players can come into the system, make it more efficient, generate revenue for government as well, and government can now understand the social safety net and provide support for those that can't afford it. I think it's quite important to start thinking about that, mainly at the subnational level. I'm an advocate of subnationals. How can the state government start to really say, oh, wow, we have a state hospital, we have a teaching hospital. How do we bring key players from the global space to manage these institutions for us? We could always have maybe 51% or whatever. I think today is not for the debate of what percentage they should have, but how do we unlock some part of that in a way that they bring funds into our system, manage our system, and can use some part of those funds to pay for the very socially vulnerable people. Then the public-private initiatives I've talked about as well. There is a need for collaborative efforts. How can we combine resources and expertise from both sectors, private and public, to advance health outcomes and improve healthcare access and delivery? Example would be, can we bring the government, the NGOs, and private companies to fund and implement large-scale health initiatives as we need today? Then lastly, my last P is the people. The investment in human capital is very key. And, at the end of the day, healthcare financing can never be complete without really talking about the continuous investment in education and training to build the skilled workforce. So that's some of my thoughts on how we can make this work, leveraging payments, partnerships, public-private partnerships, as well as really investing in our people.
Thank you, Dr. Lukman, for that expose on some of your insights into innovation in healthcare. And so just briefly, I want to bring in Ms. Kemi Olawoye into the conversation. Ms. Olawoye, are you with us? Yeah.
Yes, I am.
All right, thank you so much. So you're welcome again, and just introducing her. She is the co-founder and CEO of Baby Migo, which is Nigeria's fastest growing pregnancy and parenting community. And Abayo says she's so passionate about reducing the incidence of maternal and child mortality in Africa through the use of technology. Baby Migo is a startup focused on providing expert-verified, locally relevant health information, education, resources, and concierge services relating to pregnancy, parenting, and childbirth. Since inception, Baby Migo has reached more than 200,000 users across multiple locations in Nigeria, including vulnerable women in hard-to-reach areas. Baby Migo has been featured on YouTube, Forbes, and The Time magazine, and is backed by Facebook and Google. And it's also the recipient of Google Startups Black Founders Fund in Africa. Kemi is a recipient of several awards and recognition, including the 16th edition of the Future Awards Africa in Advocacy and Activism. She's been the 2021 Women Entrepreneur and Spirit of Jesus by the U.S. Department of State, 2021 African Choice Awards, Young Entrepreneur of the Year, 2020 AXA 50 in Tech Female Entrepreneur, among so many other, awards that our panelists today has won. So you're welcome to the NSSF Fireside Chat today, Ms. Kemi. It's a pleasure to have you here with us.
Thank you very much for having me. It's such a pleasure to be here.
Thank you. So can we just get a brief insight into who you are and what you do, so that we could just leverage on that into the conversation?
All right, then. Again, thank you very much for the opportunity to be here, and a big thank you to the Nigerian Solidarity Support Fund for this opportunity. What we do at Baby Migo, so Baby Migo is a platform focused on providing expert-led, locally verified resources, information on pregnancy, parenting, and motherhood. So our target audience are mothers, but by extension, and especially in this age of millennial parenting, I would also say fathers, because we now also have antenatal classes for fathers as well. So that's what we're really focused on. By extension, one of the things that we've also done at Baby Migo is to also have a health insurance program for mothers as well.
Oh, great. It's good to hear that mothers have some form of health insurance. Is that integrated into the Nigerian health insurance scheme, or is it an independent health insurance platform that you advocate for them?
It's an independent of the trust platform that we have, and we worked on in partnership with one of the private HMOs. However, we're definitely looking into and having discussions to see how this can work for government bodies and organizations. And it's also important for me to mention that when we talk about health economics and really access to healthcare, affordable healthcare, and not just even affordable healthcare, but also quality healthcare, it's important for me to mention that a lot of health insurance programs, even private health insurance programs, do not give access to this. You would see a lot of people that are, in organizations, and they have HMOs, and they would say, oh, my HMO will not allow me to, it's not going to cover pregnancy. And it's really because of the dynamics of maternal health. The way health insurance, as we all know, works is that it's a pool of people putting money together, in a particular place. And then when something happens with this person can't leverage from the pool that has been put together. However, the dynamics of pregnancy and parenting and motherhood is that it must happen. When a woman is pregnant, there are different stages that would happen: first trimester, second trimester, third trimester, and all of these things would really eat into the pool. So a lot of health insurance companies do not include, it's really the very premium ones, or if you have been a part of that health insurance for a certain period of time, that would allow access to healthcare for pregnancy and parenting. And that's why one of the things that we decided to do at Baby Migo was to partner with a private HMO to see how we can have a maternity insurance program, and we call that Mama Care. One of the things that we've also done is also to begin to engage, because I always say that having a baby is not cheap. It's when you have a baby and you start buying diapers and food and all that kind of stuff that you realize how not cheap having a baby is. And one of the things that we've also started to do is to engage the private organizations, to engage hospitals, to see what we can do to ensure that healthcare is affordable when it comes to having a baby, pregnancy, regardless of the mode of delivery, and even after the baby is here, because we know that the first 1 year of a child's life is really full of, of course, a lot of immunizations, a lot of pediatric visits, a lot of assessments, and so much more.
All right. So thank you so much for that expose on health insurance and the intersection between what you do and for our mothers. But briefly, before we engage the audience, because there are some questions that people listening have put in, I just want you to give us, your experience and how the economic challenges have impacted Baby Migo's operations, especially in underserved communities. I don't know how the economic challenges have affected all that, because, of course, if you're doing insurance, even looking nationally now, the premium of health insurance premiums have gone up and all that. So how are the present economic challenges affected that your operations, basically?
Well, of course, we know that the current economy has had such a huge impact on everybody, individuals as well as organizations. Definitely, I'll take the first thing. We definitely have to be funding. At Baby Migo, we're very thankful for our partners that have currently supported the work and are still supporting the work that we're doing to ensure access to affordable and quality healthcare for mothers across Nigeria, including mothers in underserved communities. However, funding definitely continues to be an issue. And I think that in line with that, it's also important for me to also mention that the health-seeking behaviors of mothers and just really Nigerians as well has also been a bit of a challenge. The fact that even with access sometimes to quality healthcare or even bringing things in a more affordable manner, the fact that people do not necessarily see healthcare as something to put money into. I would always say that a typical Nigerian woman would rather pay a premium on a maternity photo shoot than to pay a premium on healthcare to have their babies, and it's really, really quite sad to see. So I would say that health-seeking behaviors continue to also be a major issue in addition to funding. I was also going to say that another thing though that I'm just really proposing some of the ways that we've navigated this at Baby Migo. One key thing that we've always done at Baby Migo is with regards to health workers collaboration. We're very, very keen on collaboration, because the thing is that because of the dynamics of our healthcare sector in Nigeria, it's very tough for us to say that every mother is going to see an OBGYN every single time she has a complaint on her pregnancy journey, or even after she has a baby. And so one of the things that we've done is to ensure health workers collaboration, ensuring that we bring on board midwives, even other specialties like women's health physiotherapists, psychologists, just really to ensure a well-rounded and holistic approach to healthcare for mothers. Another thing that we have also done, which we realized that in the long run will also help to, I'll say, cushion our healthcare system in Nigeria, is education. We're very, very big on education. Oh my gosh, we're so big on healthcare education. Like I said earlier, we now have an antenatal program for dads, because we realize that at the end of the day, when mothers and fathers, by extension, are educated and knowledgeable about different things as regards their journey in pregnancy and just really about their body, it's easier. It doesn't have to get very bad, and then we now put a burden where we are going to the emergency room and things like that, putting a burden on the healthcare system before. So when we educate them from things like, what are the danger signs to look out for in the first trimester? What are the danger signs to look out for in the second trimester, third trimester? These are the things that you should look out for. This is when you should worry. These are things that you can do to prevent this, this, and this. It has been extremely helpful. And again, also educating even their partners. And what we always say is that we encourage our partners to advocate for their wives and their girlfriends and all of that. So education, health education has been very crucial to the work that we're doing at Baby Migo to ensure that we don't overburden our healthcare system, which is already, as we all know, very fragile. I don't know if you can hear me, but I also wanted to add to that. Sorry, I also wanted to add to that. Another key thing is also with regards to leveraging technology. We know that telemedicine cannot be the solution to every problem in the healthcare sector, and that's just the honest truth. The dynamics of healthcare and just really, seeing a doctor requires that at some point there must be some physical interaction. Where, for example, for a pregnant woman, you need to maybe palpate her abdomen, you need to maybe check the cervix and things like that. But leveraging technology to meet halfway has been very crucial for us. So not everything needs to be done. Mothers don't need to continuously go to the hospital for everything. There are some things that we have realized that, this thing can actually be done remotely. This thing can actually be done virtually. And so again, it helps to reduce the burden on a healthcare system that is also already very fragile in its current state.
Oh, okay. Thank you so much, Ms. Olawe, for that. I'll just say before we answer some of the questions, because the questions in the chat box are for Dr. Lukman and Dr. Aliwu have presented earlier. I would just like to say that as a startup in Nigeria, what are some of the challenges you face? Because a lot of our people are listening in. A lot of people may also have one or two ideas that they have up their sleeves, and they'll be looking at starting up something. Because as NSSF, what we're really doing is we're interested in youth advocacy, bringing youth into the healthcare space, trying to encourage them to also look at some of the healthcare challenges we have among mothers, among children, generally, and then just to see how we can, bridge those gaps, But as a startup in Nigeria, how were you able to overcome some of your initial challenges that you faced, and what were those challenges? So just as a source of encouraging so many people listening in onto this conversation, I don't know if you can share your insights on some of the challenges you faced as a startup.
Yeah, of course, I mentioned funding earlier, but the second one I'd want to mention for startups in Nigeria is in regards to adoption. The typical Nigerian is not very keen and so excited to adopt new technologies and new solutions for healthcare. In developed countries, you would see so many solutions for mental health, for maternal health, for child health, that citizens and people are actually adopting on the go. However, in Nigeria, you find that in as much as you are doing what you consider is best, and you are doing all of this amazing work with innovation, you have spent hours brainstorming with your team on something that is very innovative, you find that unfortunately, adoption can be quite tricky. And so I would say that my recommendation to anyone who is looking to have a startup, who is looking to start something in healthcare, is to find the meeting point between what you think is amazing and what your audience also thinks is amazing. Because the challenge sometimes as well for startup founders is that we're so innovative and we're building all these creative solutions, all these innovative solutions, but our target audience they don't want it to be as innovative as we want to make it innovative. And so I'll encourage that you're doing market research, and not just research and just checking on the internet, actually engaging with your users, actually having conversations with them to be sure that the innovations that you're putting forth are things that they're going to use on a day-to-day basis, on a week-to-week basis. You can just really be doing something that you're like, okay, I want to create an app for something, but all your users want is just to send a code on WhatsApp, as simple as that, and you're spending so much time building something that people are not going to use. And I also must say that I really cannot blame startup founders, because we're now in the age where innovation is a thing, which is amazing, but there's also some form of glorification of building complex solutions, because we feel like, oh, it's exciting to build these really complex solutions. But at the end of the day, and I'm going to share my final thoughts on this question. I remember recently there was a bank that changed the interface of their application. And as a founder, I was like, oh, this is actually really nice. But imagine my surprise to go on Twitter and see so many people criticize, saying that we like to be our team was like that. Oh, the way this thing was, it was very easy for us to use. I beg, all these things people are just putting. So it really can be an issue, really finding that meeting point as a founder, as a startup founder, innovating, creating these amazing solutions and ensuring that your audience are adopting it and is really, really relatable to them on a day-to-day basis.
For that, let me quickly go to our audience who have a question for Dr. Lukman. I think that one of the questions from Oluwatoyin Adesope is asking that how do we leverage on research and evidence? How do we leverage on research and the evidence from the research to shape our service provision? That question is from Oluwatoyin Adesope. Dr. Lukman, over to you, sir.
Yeah, thank you so much, Dr. Adirugbe, and thank you to Oluwatoyin as well. I think for my understanding of the question is, how do we leverage research and evidence? Is it to innovate? I just want to be sure. How do we leverage our research and evidence? Can you hear me?
On my own screen. Maybe you are sharing. Are you sharing your screen?
Dr. Lukman, are you there?
Yes, I'm there with you. So
Okay,
the question, let me ask the question again, please.
All right, the question says, how do we leverage on research and evidence from research to shape our service provision? How do we leverage on research and the evidence is generated from that research to shape service provision?
Oh, thank you for the question, Oluwatoyin Adesope. It's a very good question that fits what we are trying to achieve. We always advocate for evidence-based policies, evidence-based actions, and this is a clear example of you understanding the context of everything has to be evidence-based. And the idea of that is whatever, depending on the type of research that you've carried out and the outcomes of such research, the evidence you generate from that needs to undergo translation into actionable steps. Because, for example, if you carry out a research and you figure out like, oh, for males 50 years and above, they need to be tested for their PSA to prevent prostate cancer. Now you need to go through the steps of how do you really execute the outcomes of that research in a way that it translates to improving health outcomes. You don't just publish that research and forget about it. You don't just go present it. Yes, presentation is part of really sharing the awareness, but now how do you really use it to inform policies? That's one step. How do you start to advocate based on the evidence you have? Do you need to form a policy advocacy group, or you need to leverage existing policy advocacy groups that will go to government, that will go to policymakers to let them be aware, like, oh, this is the new thing we figured out. This is evidence-based. How do you implement it as a policy that starts to help improve health outcomes? How do you start to bring about the screening? From what we figured out, we know that, yes, if you screen kids at birth, you can be able to catch hearing loss early. Then how do we start a child screening program in our state? I'm always an advocate of subnationals. How do we really ensure that within our state, we have a system that other states are envious of based on the research we figured out? So it's really leveraging the outcome of the research. Yes, it can help improve our services within our practice, but beyond just our services within our practice, it should be shared as presentations in conferences. It should be taken as policy memos that are published. It should be taken as op-eds that are published in the papers as well to share advice on these are the new things I've found based on this field. Then beyond that, it needs to be kind of advocated upon, meaning sharing with government to let them know these are the basic steps that we can take to start actualizing improvement of health outcomes, leveraging that research. So it's multifaceted beyond just our private service that we're trying to improve. We need to also expand it to create awareness on how to improve the outcome from that research. I hope I've tried to explain how we can leverage that.
Yeah, thank you, Dr. Lukman. Yeah, you did. But a second question just came in for you.
Okay.
Thank you for an excellent presentation. And this question is from Stella, saying that you mentioned the possibility of private sector participation in relation to potential sources of funding healthcare infrastructure and systems, including potentially privatizing some public healthcare facilities. She's wondering whether, given our current realities, it is possible for private sector to provide quality, affordable healthcare in Nigeria. And is there a risk of making healthcare only for the elite that can afford it? She's wondering if a balance can be struck.
Oh, wow. Thank you so much, Ms. Stella. That's a very good question. And I'm sure Dr. Adirigbe will attest to this. We've had conversations and debates on this back and forth several times. My opinion, and remains my opinion, and it's been evidence-based as well. I live in the US. I spend a large chunk of my time here in the US, and I also travel around the world for work. More of what I've seen is for you to be able to drive excellence, for you to drive innovation, for you to drive efficiency, government needs to hands off a large chunk of this institution. We've seen what we have on ground. Many of us trained in Nigeria as physicians. I trained at University of Ilorin Teaching Hospital. I did some of my training in Lagos State University Teaching Hospitals. The potentials in these institutions are not being maximized. Barely 10% of the potentials. This is anecdotal. This is not from research. Barely 10% of the potential of those institutions are what we are currently maximizing as we stand today. My own thesis is, in the US and in many parts of the developed world, we've seen how the private sector, how capitalism has driven innovation, efficiency, and all that. What we can do, and what I've advocated for, and what I will still continue to advocate for, either on the subnational level or the national level, many of our teaching hospitals, which are tertiary institutions, as well as our secondary facilities, need to be privatized. And the privatization has to be done rightly. I think that's the rate limiting step. We need to identify organizations that have run profitable health institutions to take this over. They could have 51% and government retains 49%. Privatizing this will unlock some capital for government as well. Privatizing this will also make the doctors and the healthcare workers more efficient, and they are employed by this private organization and not government. So government does not need to budget salaries for doctors, for nurses, for pharmacists, for technicians that work in these hospitals. And that really unlocks a large ton of funds. And some of this funds can be put into a management fund or a VC fund that continuously gets invested. And a large part of that, and that's where the question comes, how do you balance the affordability and that can really be used to identify those that don't have health insurance or cannot pay. Those are really socially vulnerable people that government can really help supplement their payment. I think that's my own idea of how this may work. Get the best of private institutions that can really take this over, get them to take it over. You have some terms with them, they pay a lot ton of funds to really take a large share of it. They run these hospitals global standard. Those that travel across the world to get healthcare, once they figure out, like, yes, within the confines of our country, what we're going to get in Turkey, in India, in Saudi, or here in the US or in the UK, we can get something similar in Nigeria as well. Yes, they may be willing to pay some part of that. They may not be willing to pay everything and stuff like that. That saves them the air ticket, the hotels, and the extra Forex premium that they need to pay to get the services in the US or in the UK. So now they're getting their services in Nigeria. Our people are employed, more funds coming to the country. So that is my own. I know that there will be a lot of pushbacks from different stakeholder groups, but if this is well managed and the doctors see, like, yes, it makes them more efficient, it brings world-class facilities for them to practice, our patients are better, the government has enough funds, and it unlocks this dead capital, like I say. You can't go to any of our tertiary institutions and be proud that that's where you train or this is where people are being treated, until we start to think of efficiently privatizing this in a way that is seamless, in a way that is phased out. Then I think we will be talking of, like, yes, we are really the giant of Africa that we should be.
Thank you so much, Dr. Lukman, for that. A question came in for Ms. Olawe at the chat box. First, this is from Isaiah Itzwa. Is trying to look at what your opinion is about the role of culture in shaping childhood mortality in this part of the world. How does culture intersect with what you do, especially in terms of child mortality? Is culture, a stumbling block, or is it an encouragement? How does culture intersect with what you do in Baby Mego, and how can that leverage better health outcomes for Nigeria?
Yeah, sorry, can you hear me?
Yes, I can hear you.
Oh, okay, all right, thank you. Okay, so I think culture plays a huge role, especially when it comes to maternal health, where, sorry, just a minute. I apologize. I was saying that culture plays a major role, especially for something like maternal health, where there are so many cultural beliefs and values. In this part of the world, people would say things like, when you have a baby, you need to baby's first bath must be bile with palm oil and soda. There are lots of beliefs around the umbilical cord management, which we all know that many of these beliefs are contrary to the recommendation by the World Health Organization. And so one of the things that we have realized is that, one, we need to use language. We need to speak the language of the people. And that means that, for example, there are things that you would need to say in Yoruba. There are things you will need to say in Igbo, because you must be able to relate with these people. And one of the things I always tell my team, because we do a lot of health education, is that we must acknowledge where these things are coming from. Because a lot of times, something would even ask you, they would say that, well, you're telling us that we should not use lantern to manage the umbilical cord. My father did this. My grandfather did this. My great-great-grandfather did this. And it worked for them, and they're alive. So what do you mean that you are saying that we should not do this? That there's an organization somewhere that saying that we should not do this. So I feel like one key thing is to ensure that we are managing and acknowledging these practices before we now, tell them that these are the recommendations by international organizations, and this is why is a better way for them to handle this situation. So I think one, acknowledgement. Number two, sorry, I guess you can see the audio.
We understand. We understand that.
Thank you.
Thank you, Ms. Kemi. Thank you. We recognize the fact that we have another listener there that is trying to get your attention.
Yes.
And so, yeah. So, okay. So I think there's another question for Dr. Lukman on the chat box. But before I go to that, I just want to say something brief about NSSF and what we do, especially in some of the challenges that has been stated. One of the funding gaps that we notice, especially with regard to the pillars of healthcare, is what NSSF as an organization tries to address. So NSSF is we provide some grants to agencies of government, so to implement certain programs in the healthcare space. And more recently, there was a project by NSSF that we're just trying to wind up. It's called the SCURI, which is to strengthen our optimized outreach sessions in routine immunization, whereby we support states and communities and subnational entities to actually get to outreach areas to provide some routine immunization services to our members of the community. And, a lot of some support was granted to the National Primary Healthcare Development Agency in that regard to support 3 states and to carry out this activity. And apart from that, we also are interested in some youth advocacy in trying to reduce maternal mortality, strengthen vaccine advocacy, and to provide, get youth interested in the conversations around the healthcare space. And this is what NSSF as an organization stands for. And of course, we try to bridge some of those funding gaps, realizing that government cannot do everything alone. And so we try to contribute our quota in trying to solve some of that problem.
Dr. Dare, you're muted.
Okay, sorry, there's a question from Mr. Idris Rabiu saying, good afternoon, sir. How can you overcome the problem of getting information or data from the primary healthcare system? Another question is to Dr. Lukman.
Okay, yeah, I will attempt to answer that based on my understanding of how the primary healthcare system kind of currently operates. So I think it's, I'm not sure of what the procedure is. It's either, I think maybe you need to reach out to their system of, depending on the specific primary healthcare system, depending on the state where it's located, I guess the primary healthcare system ideally kind of is under the purview of local governments, even though there's a National Primary Healthcare Development Agency that serves as the governing and more like a leader to ensure the smooth running of these institutions or these organizations within the different local governments. So I think the direct thing is, we know many of these primary healthcare centers either have their data in paper format, or they don't have data at all, or maybe very few of them may have electronic medical records where you can have access to data. It may be as simple as really reaching out to the leadership of these individual primary healthcare centers where you want data, or really, if you want it at a higher level, you may be working with the National Primary Healthcare Development Agency. They have a data system, I think DHMIS or something like that, that is not really a comprehensive data system, but gives you data on immunization and basic things that you may need. So I think it's very dependent on the type of data you want, and depending on the geography, be it the state or the local government where the primary healthcare center is located. So I think depending on each local government, they have different procedures of reaching out to the leadership of the institution. But if it's beyond that, then if you want an aggregated data level for primary healthcare centers in the country, then you can work with the National Primary Healthcare Development Agency that has some form of data, which, even though it's not a very comprehensive EMR data, but they have data on, like I said, immunization, on, I think, maternal health visits and stuff like that. So I think I've been able to answer that question.
All right, thank you, Dr. Lukman. I think we initially had some questions for the Honorable Commissioner of Health in Edo State, but I think is stepped out of the meeting to attend to some other issues. I can't see any other question in the chat box, but I can see a comment from Dr. Lukman saying regarding to his last question, trying to say that government will still need to have a social safety net that objectively supports the socially vulnerable people. Exactly. I think I agree with you on that. And so I don't know if there's any other question. Is there anybody that wants to also make a comment or ask a question before we invite Dr. Fejiro to appreciate our panelists this afternoon? All right. Okay. So in the comment box, Dr. Ayole F. Ijadunla is saying that Dr. Lukman shared an insightful presentation on health system strengthening and also provided an actionable perspective on ensuring vertical programs are done. Yeah, I think I can't really see that comment. On ensuring that vertical programs are de-emphasized in the health systems. However, it is essential to create a sustainable structure around key stakeholder engagement at both subnational and federal levels. First, each level of government should have an office of the stakeholder management in the health outcome space. And secondly, he suggested that stakeholders include critical government MDAs, development partners, health workers, civil society organizations, corporate private entities. I think I'm having a problem seeing this comment fully. Thank you, Dr. Ayole Ijatui from IFE, providing that comment to us. Thank you so much. All right. If there are no other comments and questions, can I invite Dr. Fejiro to give a vote of thanks for everybody on this call and for our panelists?
Thank you, Dr. Adedayo. I think I see a last question here. The person, Idris Rabiu, is asking that most primary health centers, they have health information professional that can manage the data. So what should be the way out? I think that question should be directed to Dr. Lukman.
Yeah. So I think for the context of the question, I'm just trying to shape in my head. Yes, I guess, yeah, the goal is not to help manage the data for the primary healthcare center. I guess Mr. Rabiu is trying to have access to data for research or things like that. And I guess it's also very important that you understand the requirements of each different primary healthcare center when you're about to access data from them. Because data, especially healthcare data, is very, very delicate, and it's not something like you can just go and get data from anybody. So I think it's important you have to understand what is the requirement for this primary healthcare center, who do I need to write to, rather than just going to maybe the health information professionals, really going to the management and requesting specific data for the reason why you need it and working with them to get the data you need for the work you need, and also painting a value proposal for them as well in a way that they see the benefits for their hospital, for their institution, for their patients, that the outcome of your research can be beneficial to them as well. So I think that's my own take on how to access data from primary healthcare center. Yes, there are primary healthcare center, health information professionals, but I don't think it would be appropriate going to them directly rather than going to the management to request the approval through their requirements in their respective primary healthcare center. And if it's at the national level, National Primary Healthcare Development Agency has this aggregated form of data that you can have access to that gives you some form of visibility across the country and the number of primary healthcare centers we have, what are the things that are happening in these primary healthcare centers. And they have a new, not new, but like an ED that's very functional and very active, and I'm sure he's always willing to provide those things that you need. Yeah.
Thank you, Dr. Lukman Lawal. This is really to appreciate you for your time that you spent with NSSF today and our participants, enlightening us on the economics of health. Thank you for being available. We really appreciate you. We thank you, Kemi Olawuye, for your time as well. Thank you for being with us. And even though in absentia, we just want to appreciate the Commissioner of Health at those states for taking his time out to be with us. I hope this has been truly insightful for you attending today. And I hope that you can take the learnings from this session and apply it in your work, whatever you're doing in the health space, to improve the outcomes that we have in Nigeria. And with everything that is happening, we know that we can count on everyone to make their own inputs into the country and make it better for us. Thank you very much for joining NSSF for this webinar. We have a poll and we would like to take the poll questions now just before you leave, so that we can get feedback from you on how the session went. So can we have the poll now? Sega. It will just take a few minutes to answer the questions and so we can get feedback and we can improve on our next section. Are we ready?
The poll is going to come up when they exit the webinar.
Oh, okay. Thank you very much for that. So just wishing you a happy afternoon. And yes, the polls are up.
The poll is up.
Is up. Kindly just fill it before you exit. Thank you very much.
All right, so thank you so much, everyone, again, for coming today. And on behalf of the NSSF, we thank you so much for joining. Let me appreciate Dr. Lukman Lawal, is the head of Global Expansion Program of Mayo Clinic in the US. Ms. Kemi Alawaye, the CEO, founder of Baby Migo, and Dr. Samuel Ali, who is the Honorable Commissioner for Health in Edo State. I also want to thank all our participants and for coming and listening in today. We thank you for attending. And as we go ahead, we urge you to continue to join NSSF in trying to, create conversations around, the health sector and how best we can drive solutions together in improving health outcomes in Nigeria. So once again, we thank you and urge you that you should take the exit poll for this meeting. And we appreciate you and urge everyone to have a good afternoon. Thank you so much.